There are several different types of incontinence. The main one that we see in clinic is stress incontinence. So stress meaning this only happens when I'm under periods of stress. Not I'm feeling stressed out, I'm having a bad day, but I'm exerting myself. Trampolines, we hear about it all the time. Jumping, high intensity training, squatting, picking up heavy items. So this is the most common form, is most reported by women. Patients often report do not leak when they're undertaking activity, but that they do leak or spurt urine when they're undertaking activities such as coughing, sneezing, laughing, sometimes during intercourse, lifting heavy objects and babies, and then subsequently they feel that they're unable to take part in sports like activities like trampolining, squatting, weight training, high intensity. Then we have the catch-22 where those patients then start to put weight on, which then causes its own issues. It's very common post-baby delivery, and some women never do recover full continence, and sometimes actually managing symptoms is a key. This is also more likely to happen when we start to carry a bit of weight around the middle, and unfortunately the menopause does tend to do that quite a lot. Also, anything that puts pressure on the pelvic floor, whether that be a lack of pelvic floor tone or a lack of maintaining the pelvic floor, as we see a lot in clinic. Now, urge incontinence, so this is slightly different. So this is the second most reported, and patients will often describe there being a trigger to incontinence. In clinic, I often see that the two of these are usually associated, so stress incontinence and urge incontinence. I call it latchkey incontinence, so basically people put the key in the door, they can't get the key in the door, they need to go, and by the time they get to the bathroom, they've had a leak. It's more difficult with this. It's usually got a link to stress incontinence. I'll give you an example. I had a patient who found that certain situations would always result in urge incontinence, but if she wasn't in those situations, she was fine. And with that particular patient, yes, we found that there were some physical issues, so changes from childbirth, but also we needed to look at interrupting the pattern of her day. Another thing that we often do with patients as well is we start to look at their bladder function. So keeping things like a bladder diary is quite important, and often in clinic the nurses and I will talk about using things like the Squeezy App to see if there are patterns evolving here. Like I say, urge incontinence is a little bit more difficult, but it's not something we don't get over. Overflow incontinence, something is more down to the mechanics, to be fair. So this is when a bladder does not empty fully. Usually this is down to an obstruction of all sorts of different things. It's not something we see in women particularly. It's more what we would see in men. In other words, the flow is being blocked, but usually by something going on with the prostate, difficulty in peeing, an inability to find relief, incomplete emptying. Sometimes there's a drip or a leak. It tends to happen in men more than it does women. And functional incontinence, the bladder system works perfectly, but for some reason the patient is unable to get to the bathroom for mobility issues and wets themselves. This could be down to either a temporary physical disability, sprained ankle, broken leg, or it could be due to something more serious with like an ongoing problem like MS, for example, where patients need that little bit more support to be independent. And finally, the reflex incontinence, and this is usually resulting from a spinal or neurological trauma, which means that the message from the brain to the bladder just doesn't happen. This is seen with people with, like I say, things like MS, spinal cord injury, and often there are reasons for that.